Hello, this is Dr. João Flávio Nogueira from Brazil, and this is the second part of the endoscopic ear dissection. And this dissection is going to take us to the inner ear and also to some structures that are beyond the middle ear. We already did the endoscopic dissection, just for you to understand, middle ear dissection with the structures, ponticulus, subiculum, and funiculus. And now we are going to open the cochlea and the structures that are nearby these inner ear structures. So the first thing is we remove this completely the ossicular chain, we remove the stapes, and then we open the vestibule. Once we open the vestibule, we open also the cochlea, and once we open the cochlea, we see the scala tympani, which is this one, and the scala vestibuli, which is this one. So it's very important to understand this angulation and to understand this anatomy, especially if you perform cochlear implants, to follow the fustes, which is a very nice anatomical landmark, which is actually the floor of the scala tympani region. And of course, if you want to put your electrode inside the scala tympani, if you follow the fustes, there's a very big chance of your electrode to be inside the cochlea. And this is the vestibule. The facial nerve is above the vestibule is open, and we see a small white sac over there. This is the endolymphatic sac, which is a very different view from the traditional view. Of course, we see this view in a very good way to understand the position of the endolymphatic sac. And also, if you angulate a little bit more to this region, to the lateral region, we will see the entrance of the posterior semicircular canal. So we could add a little bit just to remove a little bit of this bone part that we cannot see. And then if we angulate, we are using 4mm 30-degree endoscope. We see the hole over there, which is the entrance of the posterior semicircular canal. And these white spots that we can see inside the vestibule, these are the otoconia. So this is very important, and this anatomy is very nice. Inside the vestibule also you have the spherical recess and the elliptical recess. The elliptical recess is above, this is the vestibular crest, and then you have the spherical recess. The elliptical recess is the attachment of the superior vestibular nerve, the spherical recess is the attachment of the inferior vestibular nerve, and then you have the vestibular crest separating these two structures. So once again, we see the endolymphatic sac, this is spherical recess, and the elliptic recess will be above, and of course the vestibular crest between those. Scala vestibuli over there, that because it goes directly to the vestibule, and the scala tympani down there because it goes directly to the round window membrane and the tympanic cavity. So the next step here in this dissection is to demonstrate the anatomy and to try to open a little bit more the superior part of the cochlea to see the middle turn, and also try to see the apical turn of the cochlea. So if we draw a line between the cochleariform process, which is a little bit more to right, and the carotid artery, in the middle between these structures we start to drill, and then we can see this structure, which is the middle and the most apical turn of the cochlea, and also trying to delineate the modulus, and also trying to see these structures inside the cochlea, the scala vestibuli and the scala tympani. And also, if we curate a little bit of, if we drill a little bit down there, try to unite the cochlea with the vestibule, we will see the fundus of the internal auditory canal. At this point, in a real patient, the dura, there's no CSF leak because there's no entrance to the central nervous system. But once we open the fundus of the internal auditory canal, which is the region between the modulus and between the vestibular nerves, once we reach this region, we will see the CSF leak coming out. So we have spherical recess, elliptical recess over there, vestibular crest between the two, endolymphatic sac over there, facial nerve is there. This is the modulus and the region of the scala tympani and scala vestibule of the middle turn and the apical turn of the cochlea above over there. This is the region of the fundus of the internal auditory canal. So we need to open this region in order to try to see the internal auditory canal, and in order to try to see the cranial nerves that are inside the internal auditory canal. So we can open with several instruments, ultrasonic aspirator, piezo surgery, drill, or curette, of course. This is a dissection, so we try to use the curette, and once we use the curette, we already open the fundus of the internal auditory canal. We see there is a small membrane. We open this membrane, and once we open this membrane, we are already inside the fundus of the internal auditory canal. So we saw in the vestibule the elliptical recess and the spherical recess, and now we are open this small membrane to go inside the internal auditory canal to try to see the cranial nerves that are inside the internal auditory canal. Inside the internal auditory canal, we will see the cochlear nerve in the left. Above the cochlear nerve, we have the facial nerve, and in the right, we will see the two vestibular nerves, the superior vestibular nerve and the inferior vestibular nerve. So we open the fundus of the internal auditory canal. There is some arachnoid over there, and we can use a section, we can try to delineate better the anatomy. Of course, in a real life, a real patient, we would do a very big exposure or a bigger exposure in order to try not to injure any cranial nerves except the cochlea that we open, of course. And then once we aspirate there, we can see the cranial nerves. In the left, going inside the modulus, we have the cochlear nerve. Superior to the cochlear nerve and a little bit anterior to the cochlear nerve, we have the facial nerve, and posterior we will have the two vestibular nerves. So we have the cochlear nerve, the two vestibular nerves over there, and between we have the facial nerve over there in the most superior part. Yes. And then we have the facial nerve, which is that white thing over there, more white in the center, the vestibular nerves, and the cochlear nerve, which is more left to our screen. So we have all the four cranial nerves that we can see inside the internal auditory canal going to this route. The facial nerve goes in this direction. So the labyrinthine segment of the facial nerve goes superiorly to the geniculate gangle and then turns into the tympanic segment of the facial nerve. Then we see all the four. You see facial nerve, that white in the middle of the image, the cochlear nerve in the left, and the two vestibular nerves going into the spherical recess and the elliptical recess. So you see all the four cranial nerves over there: the facial, superior and inferior vestibular, and then the cochlear nerve going inside the modulus. So it's a very interesting anatomy. It's a different way to look at this anatomy, going this endoscopic approach, this endoscopic access. And of course, this can be used for some selected cases of some disease, some vestibular disease, some cochlear disease in symptomatic patients with problems. This can be used to be a less invasive approach when compared to other traditional approaches using other instruments. So it's a very nice way. Or even if you don't want to do lateral skull base or inner ear approaches, you can understand the anatomy in order to try to see what is beyond the middle ear and what is beyond in this endoscopic view. Because one thing is the macroscopic anatomy. Another thing, although are the same structures, another different thing can be the microscopic anatomy. And another different thing, although it's the same structures, can be the endoscopic anatomy. So you have the macroscopic anatomy, microscopic anatomy, and endoscopic anatomy. And also, depending on the approach that you do, the structures can be also different. The same structures, the same name, the same anatomical things can have different views or can have different configurations when you see through a microscope, or when you see through an endoscope, and when you see through your bare eyes, but also accordingly to the approach that you perform. So when you do a retrosigmoid approach, the anatomical structures, although the same, are in a different configuration, a different position. When you do a translab approach, although the same anatomical structures, they are in a different anatomic configuration. And when you do an endoscopic approach, a transpromontorial approach like this one, you have the same structures with different configurations also. So it's very important to understand this concept, and to understand that although they are the same anatomical structures, accordingly to the instrument that you use to see them, and accordingly to the approach that you use to locate them. They can have different views or different configurations. So also we can see different things here in the anatomy, and one nice thing is to comprehend that the cochleariform process can be a very important anatomical landmark for the cog, of course, superiorly, that divides in some cases the supratuber recess to the anterior epitympanic space, and in some other cases the anterior epitympanic space from the posterior epitympanic space, and also the relationship between the cog and the relationship between the muscle, the tensor tympani muscle, with the geniculate gangle. This is a very close, a very important relationship. They are very tied together, the muscle, the tympanic tensor muscle, and also the geniculate gangle, which is a little bit more anterior when compared to the cochleariform process. So the cochleariform process is a very important anatomical landmark, but it does not mean that you are very over the geniculate gangle. The geniculate gangle is a little bit more anterior than the cochleariform process, so we elevate the muscle and then we see the geniculate gangle over there. And the geniculate gangle is the first genu of the facial nerve between the labyrinthine segment that we saw on this transpromontorial endoscopic approach and the tympanic segment, which we are seeing now. So the geniculate gangle also is the landmark or the place which the great petroso superficial nerve goes following the muscle and following the eustachian tube, because this muscle follows the eustachian tube. So we curate a little bit more anteriorly and inferiorly in the direction of the muscle to try to see the great petroso superficial nerve. So once we use the curette, we are elevating the bone over there, trying to see the geniculate gangle in a better way, in a better position. We can also try to elevate the facial nerve to see where the facial nerve goes inside the labyrinthine segment in the inner ear. And of course, the facial nerve is a little bit more thick when compared to the great petroso superficial nerve. So we elevate the tympanic segment of the facial nerve. This is a dissection only, so it's just a demonstration for you to understand. And we see the facial nerve going in the labyrinth and going into the inner ear. So this is the geniculate gangle when the facial nerve goes inside, and if we go a little bit more anterior, following the muscle, the tensor tympani muscle, we can find a smaller muscle, a smaller branch that comes from the geniculate gangle, which is the great petroso superficial nerve, or the GPS nerve, great petroso superficial nerve, GSPN. So we curate a little bit more in this more anterior way, and then we see a small branch of the nerve going and following the pathway of the muscle in the direction of the eustachian tube. So when we open this, we can see this great petroso superficial nerve going inside. We can elevate again the facial nerve, the tympanic segment of the facial nerve, and then we see one going inside, going down in this direction, which is the labyrinthine segment of the facial nerve, which is the weakest segment of the facial nerve, and then another going in this position, which is the great petroso superficial nerve. So again, it's a very nice endoscopic anatomy, and of course you can see this through the microscope or through other different structures, but of course sometimes accordingly to the approach and accordingly to the instrument that you use, you can have different views and different configurations. So we have the facial nerve, great petroso superficial nerve, and the geniculate gangle over there. Facial nerve going down, and the great petroso superficial nerve going into your left, following the pathway of the muscle and following the pathway of the eustachian tube. You can also elevate the facial nerve from its canal, the tympanic segment, just to understand the anatomy, just to understand its position in the inner ear. So we have here the tegmen, we have here the region of the supratuber recess, here the region of the anterior tympanic space, the cog between, and then we have all these anatomical structures, which are very important and very nice to understand. The lateral semicircular canal is going to be above the facial nerve. This is the vestibule, endolymphatic sac over there, and of course you can have different configurations, different anatomical structures. Although they are the same name, they have different views accordingly to the instrument and accordingly to the approach that you use to follow them and to locate them. So the lateral semicircular canal is there, and if you angulate a little bit more, I bet we can see all the way to the tip, to the mastoid tip. This is a facial recess, of course, and during this endoscopic view, you can see very, very nice anatomical structures and very, very nice anatomical positions. So what can we show more here? This anatomy. We already seen the inner ear with the nerves. This is the tympanomeatal flap that we can put back. Of course, the tympanomeatal flap is a little bit perforated because of the approach that we did and the drill that we use. But we can see a lot of structures. We can see the inner ear and see how close it's from the external auditory canal. It's always amazes me the distance between the inner ear and between the external auditory canal, which is not a very long distance and not a very long approach. So now we are going to show the relationship between the middle fossa dura and between the geniculate ganglion and between the great petroso superficial nerve. So this region here, the supratuber recess, is when the dura goes more close and when the dura descends towards the geniculate ganglion and the great petroso superficial nerve. So the dura is already a little bit exposed here in the supratuber recess, but we're going to create a little bit more to expose more this dura, just for you to see the relationship between the middle fossa dura and between the geniculate ganglion. This is one of the approaches that we can perform endoscopically to the lesions that are above the suprageniculate ganglion, above the geniculate ganglion lesion. So a suprageniculate approach can be performed through this way. Of course, you have to have disease, because if you have disease, you have at least space between the geniculate ganglion and the middle fossa dura. So you have ways to follow the disease and ways to remove the disease, theoretically and in the practice in some cases, avoiding more big approaches. So we can understand here the relationship between the dura and between the geniculate ganglion, just curating here and trying to see the middle fossa dura that is located in this region, the suprageniculate ganglion region. And of course, if you have disease that pushes the dura to the brain, if you have this type of disease, of course you have space. And you have space between the middle fossa dura and between the geniculate ganglion, and then you can follow the disease, like a cholesteatoma, for instance. You can follow the disease endoscopically, of course, and you can remove completely the disease, avoiding other types of more invasive or more open approaches. So you see the middle fossa dura, and you see that the middle fossa dura descends towards the eustachian tube and towards the geniculate ganglion. And of course, this is a region which has a very close relationship between the geniculate ganglion, the eustachian tube, the tympanic tensor muscle, and the middle fossa dura. So we have this very close relationship between these structures, and also you can have this kind of endoscopic approach, the transcanal suprageniculate approach, also to some regions, also sometimes to the petrous apex, of course, using the endoscopes and avoiding, whenever possible and whenever you have the skills and whenever you have the correct instruments, avoiding more open radical approaches. So the middle fossa dura is there. You can dissect completely the middle fossa dura, and you can see that the middle fossa dura, once you pass the cog, the middle fossa dura stays more superiorly, stays more in a more distant configuration between these structures. So you have the hypotympanic cells. The muscle is completely dispatched to the most anterior part. The middle fossa dura is there. Middle fossa dura. And you see the close relationship between the middle fossa dura, the geniculate ganglion, the great petroso superficial nerve, and the eustachian tube. Lateral semicircular canal is there. The tegmen is there. You can see the region of the facial recess a little bit over there. And now also we can understand the relationship between these structures and also the relationship between the inner ear, the facial nerve going in this position, the labyrinthine, the cochlear nerve goes to the modular, and the superior and the inferior vestibular nerves going to its attachment, which are the elliptical recess and the spherical recess, a lateral semicircular canal, the cog, which was over there, the artus adiantrum and the antrum of the mastoid. This is a 30-degree angulated endoscope. It's not a 45-degree, and this is also a 4mm endoscope, the same one that is used on sinus surgery. So this is inside the vestibule. If you angulate a little bit, you can see the entrance of the posterior semicircular canal. You can see the lymphatic sac in the left, above the below the facial nerve. So these are structures, anatomic structures, which are very nice to understand, very important to understand. And if we can understand their relationship and their proximity between the middle ear and between the external auditory canal, actually, the middle ear and the inner ear, we can try to understand the inner ear endoscopic approaches that we can have, that we can use for some diseases that we can treat over there. So now this is the protympanic space, the protonucleus is over there, and then we can understand the relationship between the eustachian tube, the protonucleus, which is this very new endoscopic anatomical landmark, and the internal carotid artery, and also the relationship between the internal carotid artery and the cochlea. So we curate a little bit following the protonucleus, and then we can see already the internal carotid artery and its relationship between the eustachian tube, the muscle, the tensotympany muscle, the internal carotid artery is there, the relationship between also the cochlea. And now we can open the internal carotid artery. Of course, this is a dissection. We can open just to understand, to see inside the internal carotid artery. So we open, there's a little bit of blood still. This is a very fresh head that we are using to dissect. So of course this is the internal carotid artery, and then we can see the relationship, we can understand the relationship between the internal carotid artery, the cochlea, the eustachian tube, and the canal of the tensotympany, because over there, just above a little bit, is the region that the internal carotid artery goes in an horizontal way, and then it goes directly to the sphenoid sinus, and then the carotid artery goes up in a vertical way, the paraclival carotid artery. So it's very nice. So you see the dura, you see a whole 360-degree view of the anatomy from the most anterior part in the internal carotid artery, eustachian tube, canal of the muscle. We are removing a little bit of the muscle. We see the middle fossa dura, we see the facial nerve, the genicular gangle, we see the inner ear nerves, we see the vestibule, we see lateral semicircular canal. We understand the anatomy, and this is very important, I think, not for you to perform surgery in this region, of course, if you don't want, but to understand the relationship between these anatomical structures in order to understand the anatomy, and in order to understand possibly the approaches that you can have, or the approaches that can be performed to remove diseases in this region. So you have this most superior part of the cochlear nerve, facial nerve, and vestibular nerves over there. Facial nerve going to the genicular gangle. This is the tympanic segment of the facial nerve. The middle fossa dura is there. The tegmen is there on the right side. The hippotympanic cells are there. The jugular bulb is going to be over there also. We didn't expose the jugular bulb in this case, but it's a very important way to understand anatomy. Anatomy is one of the most important things. You have to have skills, you have to have anatomy, and you have to have the instruments to perform surgery. So thank you very much for watching this video, and hoping you have liked. Thank you.